All right, we're going to go ahead and get started with this session. You currently are in the breakout room. The topic is primary care options in rural health. Our presenter is Jonathan Pattenberg. He's a principal at Stroudwater and Associates. Jonathan has a strong record of leadership in rural health care. And prior to joining Stroudwater, he was the chief financial officer and the chief operating officer at a critical access hospital. Jonathan's complete bio can be found on our website under the events tab. If you have any questions during the session, please use the chat function so that we can make sure that your question gets asked and answered. I will now go ahead and turn things over to Jonathan. I do not see Jonathan in here yet. I apologize for the delay. We're trying to reach Jonathan right now. Just give us a couple minutes to iron this out.
Hello, everybody. Thank you for joining us today. As we talk through the information today, again, what we're going to be focusing on today is really primary care options in rural healthcare. I know that we gave this presentation a couple years ago, but when we look at what has changed in healthcare, there's been a considerable amount of changes over the past couple of years, particularly with designation types, rural health clinics, and looking at all of those different factors. So as we talk through today, first what we're going to do is do a high-level overview of different regulations and information to really highlight how we can look to optimize and improve, whether it's financial reimbursements, alignment, continuity of care, and all of those different factors to improve that perspective. So when we think about it from that, again, we're going to be looking at this going forward and looking at how, again, we can improve that. So first, what we're going to be talking about is some of those definitions and regulations. Then what we will be getting into is different strategic options as to how we can designate and how we can look at different clinic types to really improve the performance going forward. Then last, what we'll focus on is certain case studies that talk about how these different designation types specifically impact not only performance going forward. Now, with the different designation types and the different changes in regulations, again, there's uncertainty as to how all of these things have changed and come about, that really as organizations, we really need to factor how we can continue to improve performance. When we look at something that recently changed relative to the RHC reimbursement methodology, this is something that caught a lot of people off guard. And it definitely impacted how those organizations could play and could start to be putting forward a viable and operating strategy to look at it from that perspective. Today, the different designation types we're going to be talking about is your federally qualified health centers, FQHCs, provider-based clinics, rural health clinics, provider-based rural health clinics also included under that, and then our freestanding health clinics, those that are only getting the fee schedule reimbursement. Now, when we talk about our definitions and regulations, again, different programs have different requirements as to how you can actually pursue and qualify for those different programs. Again, the rural health clinic has different requirements from the FQHC versus the provider-based clinic. And again, it's leveraging how all of those strategies play off one another and figuring how we can leverage those strategies ultimately to improve reimbursements for the continuum of those practices. I don't think there's anybody on this webinar today that could say that reimbursements are going up at a greater rate than your costs are. So again, I'm going to talk at that high level again, how these different factors play out and how they directly impact each of those different designation types. Now, one of the core requirements for some of the programs, particularly your rural health clinic, is being located in a rural area. Now, the Census Bureau, again, does not clearly define rural. They define what is considered an urbanized area. Now, when we look at it from that perspective, the reason why I'm going to highlight the urbanized area is there's been recent conversations where the Census Bureau is actually looking at getting rid of the definition of urbanized area. Now, it's unknown exactly how this will impact some of the programs and the ability to qualify for some of those programs. But again, as we start to look forward, there will be a change coming if they do actually get rid of that term urbanized area. It's unknown because the term urbanized area is written into federal law for pursuing some of those programs such as the rural health clinic, how the change in that definition and how that going away will actually impact that going forward. Now, right now, urbanized areas, they look at the density or the number of people within a specific area or a collective of certain census tracts that will be deemed an urbanized area. Now, when we look across the entire state of Michigan, we can see that most of our urbanized areas are in the southern part of the state. And as we look across that from a program such as the Rural Health Clinic program, as long as we are not located in one of these dark blue areas, from a rural health clinic perspective, we can really establish, again, there's other requirements, but from a rural perspective, we can really establish a rural health clinic within any one of those areas that is not that dark blue. Now, one thing I want to emphasize also is we can see that the areas surrounding those urbanized areas are very jagged. They're not standard boxes. They're not tied specifically to counties or certain areas. A lot of times they end up following roads, rivers, train tracks, certain landmarks that allow you to define an actual urbanized area. Now, when we've looked at it from that perspective, I've actually seen certain situations before where being located on one side of the road versus the other would allow an organization to qualify and pursue that actual rural health clinic program. So again, sometimes you have to get at that very granular level to be able to determine whether or not you can actually pursue that program from a designation perspective. The next are really our shortage area requirements. And for today's purposes, I'm really going to be just talking about a primary care shortage area, not looking at your dental or your mental health services from a shortage area perspective. Now, when we look at the different programs, you have your geographic HPSAs, you have a population HPSA, and a facility HPSA. Your geographic HPSAs look at a specific region and determine whether or not that region has a certain number of providers relative to the population within that geographic area. The population HPSA looks at whether or not you have a specific population that is underserved. So they may look at low income, the number of people qualifying for Medicaid, and other factors such as that to determine a population HPSA. The last is a facility HPSA. And a facility HPSA is where a specific organization goes through the process and becomes a rural health clinic or an FQHC. That actual facility would be designated as a HPSA or as a shortage area. And the purpose for that is because of the grandfathering provision tied to a program, say the Rural Health Clinic program, that eventually, if that designation disappears, that you would still be able to maintain your shortage area designation so that you can continue to qualify for, say, that rural health clinic program. Now, again, this is a map of the state of Michigan, and what this looks at is all of your shortage areas. Now, when we look at some of the programs, again, different programs have different requirements. Depending upon if you want to pursue, say, the rural health clinic program, all that matters is that you are in a primary care HPSA. It doesn't matter the score of the HPSA itself. Some of the other programs, such as the tuition forgiveness or the loan forgiveness type programs, or even the ability to get the additional incremental revenue where you can get the 10% kicker operating within a shortage area, certain programs like that may have certain scores that are required to be able to pursue that shortage designation and being able to pursue those additional revenue opportunities. Now, again, if we were to look at the rural areas and overlay that on top of the shortage areas, anywhere where you are in a green area but not in that blue area, you could establish a program such as the Rural Health Clinic. Now, one thing that's important about the Rural Health Clinic is, again, it's where the clinic is located itself, not necessarily the people that you serve. The next is your medically underserved areas. Now, your medically underserved areas, again, started back in the 70s, and look at it from that perspective going forward. Now, when we look at it from that perspective, a medically underserved area, again, looks at a specific region and a specific group of people from the medically underserved population. And again, look at whether or not those are deemed a shortage area from that perspective. Now, most of the MUAs and medically underserved populations have not been updated in 20, 30 years. In fact, if you actually go to the HRSA website and look most of them up, most of them were designated in 1978, and many of them have not been changed since then. Now, when we look at the map again, we can see that, again, Michigan has several medically underserved areas and medically underserved populations. Now, the blue is your medically underserved populations, and the orange or yellowish color is your medically underserved areas. Now, again, when we look at the certain programs, the difference between the FQHC and the RHC from a designation perspective is the FQHC is less concerned with where the clinic is located and is more concerned with the people you're actually providing services to. So when you look at it from that perspective, you can see that also there is the ability to provide those services, and there are a number of regions that are within that medically underserved area or medically underserved population. Now, one thing I also want to emphasize too is that for your FQHC program, the FQHC program does not have the specific requirement relative to the age of the medically underserved area or population like the RHC. So the RHC program, that shortage area designation has to be valid within the past 4 years, whereas the FQHC does not require that designation to be valid within the last 4 years. The last from the designation perspective is really your governor designated secretary certified shortage areas. Now, what this is this allows a state to come up with a specific plan as to how they want to designate a certain area as a shortage area from that perspective. And again, they go through different criteria to establish that from a shortage area perspective. Now, the governor designated, secretary certified shortage areas, those can qualify for the rural health clinic program. Now, when we look across the different designation types, your rural health clinic requires you to be in a rural area, and it requires either you being in a current HIPSA, a primary care HIPSA, doesn't matter whether you're a geographic or a population, or a medically underserved area, or a governor designated secretary certified shortage area. So you have to be in the rural and one of those other three. When you're pursuing a program such as the FQHC program, that one really requires you to actually serve patients from a medically underserved area or a medically underserved population. Now, one thing that's interesting when we talk about the FQHC program is it does not clearly define what patients are. It's just plural. So it doesn't say that patients are 1,000 or 500 or even 3. It just says you have to serve patients from one of those areas. And when we think about it from that perspective, that's why we see FQHCs all over the place, is because they're able to provide those services and justify that they are providing care to those people. So think about it from that perspective as you look forward. Again, as you're deciding whether you are an independent clinic right now and you're looking at different designation types, factoring really the population that you serve and whether or not you can meet those different core requirements. Now, again, there's a whole litany of other regulatory requirements to be able to participate in those programs. For today's purposes, I was just highlighting the location requirements for those instead of looking at all of those different requirements from that perspective. When we think about the fact of how our state offices can provide assistance, state offices can provide significant resources and options and information and really assist us with all of these different processes. They can provide guidance around HIPSA designations and renewals, RHC rate establishment, rural designations, and they really bring together all that information from the different conflicting or competing or opportunities around the different designation types from that perspective. So I would definitely recommend that if you do have different questions around the different designation types or critical access hospitals, definitely reach out to Crystal, to Jill, to Jeff, and others at the state office, because they can provide you with all those resources and definitely help you with the different processes and understanding this information going forward. The next area is really looking at the different designation types. So again, as we had talked about, each of the different designation types can pursue different revenue opportunities. Your FQHCs have different options versus your CAS, versus your PPS, versus your RHCs. Again, they all have different opportunities, and it's evaluating those different opportunities that will really dictate which one would be the most viable for you as an organization going forward. So first, what we're going to talk about is the different reimbursement options. The first one is your 330 grant. Now, what your 330 grant is it's funding available to your FQHCs that help cover the administrative cost and the burden for providing services to a disparate or underserved population. Next is your 340B program. And when we're talking 340B, really from the contract to retail pharmacy perspective, which is really the program that's applicable to your clinic and practice types, not really focusing on your outpatient services from a 340B, but again, that contract to retail pharmacy. And the contract to retail pharmacy program allows you to get discounted drug costs by qualifying as a 340B vendor from that perspective. Next is an enhanced technical charge. Now, your enhanced technical charge, I generally consider that anything where the technical reimbursement is in excess of what the APC payment would be. Now, in today's environment, especially with site neutral payment policy and all those different factors, we're definitely in an environment where there is an enhanced technical charge and more probability for these different designation types. But again, affords you those different opportunities. Method 2, what Method 2 is Method 2 is an option that's available to providers, specifically critical access hospitals, where they can make an election to consolidate their technical and their professional, so consolidate that UB and that 1,500 claim onto a single UB, and they actually get enhanced fee schedule reimbursement by submitting those as a consolidated claim. Tort reform, something only available to our FQHCs. And based on that perspective, because there is a limitation of exposure for those FQHCs that's written into the federal law, those FQHCs are able to secure reduced malpractice insurance cost. And then the last is your enhanced PPS reimbursement. Now, your enhanced PPS reimbursement is similar to your enhanced technical charge. Anywhere where you get a reimbursement rate in excess of what your straight physician fee schedule is, we generally consider that as enhanced PPS reimbursement. Now, when we look down, again, you can notice that several of them are green across the different groupings, some are red, and looking at it from that perspective, we notice that our FQHCs, they automatically qualify for a 330 grant if they can get it. Now, again, you do have FQHC lookalikes that can get the rate enhancement, but don't actually get the 330B3 grant. They automatically qualify for the 340B program. They do not get an enhanced technical charge. Again, they get an all-inclusive rate as an FQHC. And right now that rate we'll just say is around $175. They get tort reform. They do not get method 2, and they get an enhanced PPS reimbursement. Now, again, because that $175 rate is well in excess of what you're getting in a straight fee schedule, that's where they're able to actually get that rate increase from that perspective. Provider-based clinics. Now, again, you have provider-based clinics under critical access hospitals. You have them under PPS hospitals. And again, PPS hospitals would include all of those, your sole community hospitals and all of those different provider designation types. Now, a provider-based clinic under a critical access hospital does not get 330. They automatically qualify for 340B. Because a critical access hospital gets cost-based reimbursement from Medicare, they get that enhanced technical charge. They do qualify for method 2. Now, one thing that's interesting is many critical access hospitals will actually not pursue the method 2. And this is a big opportunity that critical access hospitals are leaving revenue on the table by not pursuing that program. I know that we're talking today just about clinics. However, method 2 is something you can pursue for your emergency room providers. You can pursue it for diagnostic imaging if the radiologist reassigns their rights to you. Again, look at all of these different opportunities. They do not qualify for tort reform, but they can get enhanced PPS reimbursement. Now, the reason why I say they can get reimbursement that's enhanced is because they do have to elect method 2 to get that enhanced rate. If not, they would get the straight fee schedule reimbursement under that critical access hospital. Now, for our PPS provider-based clinics, they do not qualify for the 330 grant. They may qualify for the 340B program. And again, that all depends upon if they meet the qualifying DISH percentage. No enhanced technical charge, no method 2, no tort reform, no enhanced PPS reimbursement. Now, from a DISH perspective, if you're a sole community hospital, you have to meet that 8% DISH. If you're a non-sole community, you have to meet the 11.75 DISH. But again, 340B offers clinics a substantive level of reimbursement that oftentimes makes it advantageous to pursue that provider designation. Now, next is our rural health clinic program. And again, this is one that's gone through a material change as of the end of last year. And because Medicare has not rewritten the reimbursement interpretive guidelines, it's still unknown exactly how this will change in the coming months. So from the 330 grant, again, does not qualify. The RHCs will qualify if they are aligned under a hospital that qualifies for the 340B program. It is an enhanced technical charge, no method 2, no tort reform, and they get the enhanced PPS reimbursement. Now, one thing that's interesting is the RHC program, because it has changed from that perspective, how and who can leverage the RHC strategy will change over the coming months. Again, larger systems can start to leverage it due to that rate that's going to increase. And the last is your FSHC. Now, your FSHCs really don't get any type of enhancement beyond the different designation types that we've seen before. Now, when we look at the different designation types, again, each one brings forth different strategies. If we were looking at pursuing an FQHC in a system, the governance requirements, unless we are a publicly owned, meaning government-owned system, we cannot regulatorily own and operate an FQHC. So if we wanted to establish an FQHC, we would have to give up ownership of that FQHC itself. Provider-based clinics, again, brings forth many different revenue opportunities. Now, again, when we establish provider-based clinics, Medicare has been pushing things such as site-neutral payment policy perspectives. And when we look at it from that perspective, again, brings forth different advantages, 340B and other opportunities. But again, to be a provider-based clinic, we have to meet the additional regulatory burden under 41365, which are the provider-based rules applicable to practices from that perspective. RHCs, again, RHC is a separate standalone designation, does bring reimbursement advantages, can bring additional revenue such as 340B and all of those different opportunities. But again, we have to evaluate the pros and cons tied to each of those different designation types going forward. Now, when we look at the new RHC reimbursement methodology, on December 27th of 2020, RHCs went through a significant reimbursement change. And starting on April 1st of this year, all new RHCs that are established, so any RHC that was not established originally under 12/31/2019, that was then changed based on HR 1868 to 12/31/20, all new RHCs that were not established or at least had an 855A filed by 12/31/2020 will be subject to the new payment methodology going forward. And that started at $100 on April 1st of this year, and it trends to $190 in 2028. Now, thereafter, it'll increase based on the MEI, and in 2021, the MEI was 1.4%. So as we continue to look forward, again, the primary difference is how it will impact the fewer than 50-bed hospitals when they're looking to establish clinics going forward. Now, on the positive side of this change in law, the rate for the independent and the greater than 50-bed clinics was much lower than it should have been in recent years. In fact, it trailed behind many of the other reimbursement rates from that perspective. So with the change in the law, all of those clinics, those independent and those greater than 50-bed clinics, will see increases in their reimbursements that will help financially sustain those clinics. We will probably also see an increase in the number of independent rural health clinics coming forward, again, because of that trending rate, which should help with the increase of access to care. Now, the biggest impact is for our fewer than 50 beds from a negative perspective. Now, from that perspective going forward, in the past, if you were a rural health clinic aligned under a hospital with fewer than 50 beds, you received cost-based reimbursement. Going forward, it is actually going to be subject to an upper payment limit, where you get the lesser of your actual cost or that upper payment limit. So if the upper payment limit's $100 and your cost-based rate's $80, you get $80. If the upper payment limit is $100 and your cost-based rate is $150, you get $100. So you always get the lesser of those two rates. Now, going forward, there was also a grandfathering provision built into that federal law. And again, any of those clinics that were owned and operated and established prior to December 31st, 2020, or had filed their 855A by that date, will be grandfathered in. And the use of their 2020 rate will be starting the point for their basket rate. And then that would then be trended forward each year thereafter based on the MEI there forward. And again, they will start most likely at a higher point, and then it'll be trended forward, but they still get the lesser of the cost-based rate or that upper payment limit going forward. Now, what I really want to show is really what does this mean for the different practices that are operating those clinics. Now, for a critical access hospital, again, this is not to put any type of political spin to say whether or not it was beneficial or not. It's solely to look at what is the direct impact from a reimbursement methodology. It's also not to look at and say, is this or is this not a viable strategy going forward? It's to just look at the impact of the change in the regulation. So what we looked at is we said, what would have happened if this law went into effect in 2016 and then trended forward based on the new methodology? Now, from looking at it from that perspective, it's $155, this critical access hospital that owned 2 clinics, and their rate trended forward to $220. So over that 4-year period, if they were subject to that MEI going forward, they would have lost out on roughly $687,000 in reimbursement. Now, for the independent or the greater than 50 bed clinic, hospital and clinics, their rate was roughly the same, $145, and it trended to $141 over that same 4-year period. So the rate actually declined over that 4-year period. But nonetheless, because that upper payment limit's going from 100 to 139, they would have picked up $330,000 in incremental revenue due to the change in the reimbursement methodology. So again, very good for the independents and the greater than 50 beds, providing them viable resources to sustain the services. On the negative, it was funded through placing a cap on the fewer than 50 bed clinics. Now, the next looks at from an opportunity cost perspective. Again, same exact clinics looking forward. And what is said is what would have happened if this law again went into effect in 2016, but instead of being grandfathered, those were new clinics that were established. Now, from that perspective, same cost-based rate, $155 trends to $220, but they would be subject to the same exact cap that a new RHC or a greater than 50 bed or independent RHC. So that $100 that trends forward to $139. Now, from an opportunity cost perspective, this clinic over that same 4-year period would lose out on $1.3 million in reimbursements. The independent or the greater would have still picked up the exact same $330,000 reimbursement gain. Now, again, this is not to say this is not a viable strategy. Most times, the $130 rate or the $139 rate is greater than that critical access hospital would receive or that fewer than 50 bed in a straight fee schedule reimbursement methodology. However, again, as we've looked at, each of those different designation types have different options that are available that allow them to determine what different designation type they want to pursue. So in recent years, we've seen a greater increase in the number of hospitals and systems that have leveraged the RHC program because of those reimbursement advantages. With the change in the reimbursement methodology, again, we're seeing that now maybe they want to be a provider-based clinic if they can meet those requirements. If you're an independent clinic, maybe now you're going to convert from being an independent to an RHC. With the rate increase, again, and the regulatory burden on FQHCs and the administrative burden, maybe with that rate enhancement down the road, we're going to see some independent FQHCs that are FQHC lookalikes maybe pursue the RHC program. Again, it's changing the dynamics as to how we're going to look at leveraging these certain practices going forward and the designation types. Next, what we're talking about is the specific strategies that organizations or clinics can evaluate to look at how that would improve reimbursements going forward. When we look at it from that perspective, again, the first opportunity is really evaluating the designation types that are available and determining whether or not the designation type that you have now is the most advantageous. Maybe you're an independent freestanding clinic and you want to become a rural health clinic, or maybe you are in a system, and again, the systems are in a freestanding group or a freestanding clinic and you want to make it a rural health clinic or a provider-based clinic. Again, we want to evaluate all of the different designation types available to us to ensure that we select that optimal environment going forward. Next is really looking at within a system environment, looking at whether or not we want to realign those practices, again, to leverage different designation types to improve the reimbursement from that perspective. Most systems may operate, a medical practice group that operates a number of freestanding clinics. Maybe we have a sole community hospital that qualifies for 340B, and we want to align them under that hospital to qualify for the 340B reimbursement. Now, again, in the past, many of these hospitals would align them under smaller hospitals to yield the uncapped cost-based reimbursement. That strategy has gone away, but there's still the ability to align them under hospitals to get rate enhancements. We just don't have to pick the fewer than 50 bed hospitals anymore. Now we can look at the 340B enhancement. Look at integrating specialty providers into practices. Maybe we operate provider-based clinics or provider-based RHCs, and we want to reach out to specialty providers and looking at integrating those to leverage those reimbursement rates under a grandfathered practice, or looking at whether or not we can integrate them into other practices. For example, with our independent rural health clinics, maybe we want to reach out and get some visiting specialists into our community now. And maybe in the past that wasn't viable when we were getting $86 in reimbursement. However, with the trending forward of that upper payment limit, maybe we'll be able to do that in an environment where we're getting $150 down the road as an upper payment limit. Again, it opens the door as to how we can further leverage these strategies. And then the last is really looking at, are there potentials to acquire independent clinics to improve reimbursements from that perspective going forward? So next, we're going to highlight some different case studies and really look at how these different things have come about and looked at from those different factors. So first, we looked at one case study, and these go in sequential order relative to the different options that were highlighted before. So what this looked at was, this was a hospital that owned and operated multiple practices, 5 actual provider-based clinics. 4 of those practices were off campus, and 1 of those practices was on campus. And what we wanted to look at was, how would the reimbursements be impacted for those practices if we actually looked at changing the designation types for those different practices? So first, what we wanted to look at was the impact of the OPPS final rule. Then we also wanted to look at was under a hospital. Again, when we did this analysis, the under and greater 50 bed had an impact on the reimbursements. I left that in to just highlight the differential in reimbursements relative to that prior methodology. Then we also updated the analysis to factor in how that would be under the current reimbursement methodology. So under the prior scenario, they were getting $143 average reimbursement across the 27,000 annual visits. Now, under the OPPS final rule for those off-campus practices, this one hospital would have lost out on about $400,000 in reimbursements due to the site-neutral payment policy perspective. If they were to convert them all to RHCs back in 2018, their rate would have been subject to the $82 rate. They would have lost out on $1.2 million in reimbursements in a site-neutral payment policy perspective. If they were able to drop their beds to fewer than 50 under that prior methodology, they would have actually gained $1.5 million relative to that reimbursement methodology. Again, because their cost per visit was $183. Now, in the current methodology, their rate would have gone to $126. Again, because the Medicare side would be capped at that $100 upper payment limit, and the gain would have only been on the Medicaid side. They ended up dropping their beds as a facility from that perspective. So what we can see is the material impact that the change in that methodology had on the actual reimbursements for that facility going forward. Luckily, they were able to make the change before, and they were able to achieve that grandfathering provision. Next is really another hospital that operated several clinics, and they had different hospitals that they could actually select where to align those clinics. So they were all operated as FSHCs, freestanding health clinics, under a medical practice or a medical group that was owned and operated by the system. And we wanted to look at if we were to align those practices under a PPS sole community hospital, or under another hospital that was actually a critical access hospital, or a blend somewhere between the two. Now, again, the regional proximity prevented many of those clinics from operating as provider-based. Now, under the freestanding perspective, when we looked at it from that perspective, they were receiving an average about $109 a visit, which is a pretty good reimbursement rate for FSHC practices. Now, making them under the short-term acute care facility would have got their rate up to $180. However, that short-term acute care facility did not qualify for 340B. So that had a material impact on the reimbursements received for that facility. Under the prior scenario, again, the rate would have been $181. However, because they were under critical access hospitals, they would have received lower reimbursements from your other cost-based services, your med-surg and other programs under that critical access hospital. They would have picked up about $3.5 million in 340B. So the net impact for them would have been about $7.1 million under that prior reimbursement methodology. Now, under scenario 4 is rebasing them in a current environment. So under a current environment in that state, both Medicare and Medicaid were set at the same rate. So that $100 upper payment limit. So they would have actually lost reimbursements. They would have lost roughly $10 a visit going to that new designation type. They still would have lost that same impact from their other cost-based services. They would have got the 340B, but as we can see, the net gain dropped down to just $1 million in reimbursement. Again, a substantive change in reimbursements due to the fact that their rate would have been significantly lower due to that new upper payment limit. Now, again, $1 million is still a lot of money for many organizations and systems, and they probably still would have gone through the process even from that perspective. But again, it highlights how they looked at those different strategies and have to factor it into that environment. Now, the next scenario looked at integrating a specialty practice into a rural health clinic. Now, from this perspective, this looks at, again, in the pre-environment and in a current environment. Now, they had a number of visiting specialists, and they were operating two different practices, a primary care practice that was a rural health clinic, and a private specialty practice that was a provider-based clinic. Under the current environment, they were doing pretty well, average of 217 on the specialty and 174 on the primary. Now, under the prior environment, they would have received $235 as a blended cost-based rate for the two practices. So they would have actually received roughly $500,000 more in reimbursements to integrate those two practices together. However, under the new reimbursement methodology, increasing the cost of that practice would be subject to the MEI for that given year. So merging those two practices in a current environment as an RHC would have actually cost this hospital money, because that rate for that independent or that provider-based specialty practice would have gone from the 217 down to $174. Again, because increasing the cost would not pass on to an increase in the rate beyond the MEI cap within a given year. Then the last was a hospital system that had engaged with acquiring an independent practice. And what they wanted to look at was pursuing an acquisition of this practice going forward and saying, right now, what were the two entities getting from a separate freestanding environment and the independent critical access hospital? What would it have done if they had actually merged the two entities from that perspective? Now, under the prior environment, the freestanding clinic was getting $97 per visit across Medicare and Medicaid. Critical access hospital, Medicare and Medicaid reimbursements was about $10 million. If they were to acquire that practice and make it provider-based rural health clinic, that rate would have gone up to about $197. The critical access hospital would have lost a little bit of revenue in other cost-based programs, and they would have picked up $183,000 in 340B revenue. So the total gain would have been about $395,000 in reimbursements. In the current environment, again, the rate would have gone from $97 up to $100, so a very minimal increase in the actual reimbursements. They still would lose the same net cost or the net revenue from the critical access hospital side. 340B is still the same, but again, the benefit is only $118,000 in a current environment. Now, one thing I want to emphasize too is that this $118,000 is subsidized by the $183,000 as being eligible for the 340B program. So if they were unable to pursue 340B, they would actually lose money by acquiring this practice from a net position, looking at it going forward. I know I've gone over a ton of different things. In the presentation, I also included a number of appendices that talk about different federal regulations and different things tied to the different programs. So I threw that in just so you can have that for different information. I know we're pretty much at time, and I wanted to get through all the information as quick as possible. So if there's any questions, I'm going to stop talking and let you ask any of them.
Thanks, Jonathan. One question would be, how do you, and I know this is not, you're not a Medicaid expert for the state of Michigan, but how do you think some of the changes with reimbursement are going to impact the Medicaid side of the equation?
That's a great question. And honestly, Medicare hasn't even figured out all of this, and it's been in effect. It's unknown exactly how it will impact the states. Now, for example, if we look at the state of Texas, written within their state law, it very clearly states that you get the Medicare rate, you get a Texas cost-based rate or the Medicare rate, whatever is lower. So in that instance in Texas, because the Medicare upper payment limit is now $100, they would be subject to that $100 upper payment limit in that state. Whereas in the past, most times the Medicare cost-based rate was in excess of how they calculated the Texas cost-based rate. So it's unknown exactly how this will play out in Michigan. I do feel that as we continue to go forward, most states are grappling with shortages and budgets and different things. So it's unknown whether or not they will apply the lower standard or those different things. Now, all of these things are written into the state plans, specifically how they reimburse rural health clinics. So if they differ from the Medicare rate, they have to submit a state plan that very clearly identifies the exact way that the clinics are reimbursed. Most of them do have the grandfathering provisions, but I would definitely check on that state plan and just look at, does it say you get the lesser of the Medicaid rate or the Medicare rate, or just look at that language. I would definitely reach out to Jill. Jill does a great job of kind of facilitating the statewide network from an RHC perspective. And this is definitely something that you guys can come together and start to have conversations how and if that will directly impact you from a state perspective.
Great. Jonathan, I do not see any questions in the chat box at this time. So I want to thank you very much for your time and your expertise. It's always great to have you on the agenda. We always look forward to your presentations. And for everybody that is in this session, I'd like to thank you from the MCRH side of things. This concludes today's portion of the conference. We will see you tomorrow at 9 a.m. for the final day of the conference. Please use the same Zoom link that you did to join today. Tomorrow we have another morning of great content, and that'll be all kicked off by the MSU Medical Student Research presentation. So I'd like to thank you again today, and we hope to see you all tomorrow.
Thank you.
Thanks, Jonathan.